Thank you. Thank you. Good morning. Not going to lie, that's going to be a tough act to follow. Kind of got right into the meat of some of those discussions first thing this morning, which is absolutely brilliant. So I'm Klaudyna Johnstone from source LDPath. This is Sanj Lallie. I know a lot of you already know both of us, but for anyone we don't know, new faces, hello. So we've got 20 minutes now, I believe, and we thought long and hard about what to do with this little slot of time. And we've split it into 3 mini sections. Yeah, a bit of a different approach today. So what I'm going to do is I'm just going to give you like a quick overview of who we are. I know a lot of people in the room already know, so just give you a bit of an update on what we've been up to recently and what our vision for the future is. Then I'm going to hand over to Sanj, who's going to talk you through our upcoming launch of it is a LIMS system. However, I call it a bit more of a LIMS overlay because it plugs in with existing LIMS systems at just about any hospital, but it's very histo-focused. So Sanj will talk you through that. And then very excitingly, we're going to hand over to Debra Padgett, who is an individual that really needs no introduction, but as a past president of the FIBMS and many other subsequent job titles that I won't run you through right this second, and I'll leave to Debra to introduce herself afterwards. We've got a bit of an exciting announcement about a working group for digital pathology that Debra's been chairing over the course of 2024. And we're now in a position where we can do a bit of a pre-launch here today. We haven't spoken about it publicly up until right now. And this publication is due to come out before the end of the year. So we'll leave the best for last. And let me just give you a quick introduction as to who we are. So at source LDPath, we've been supporting lots of NHS trusts and hospitals with their histopathology needs. Been doing this for many, many years, and more recently, in the last few years, we've also been supporting, again, individual hospitals, trusts, or pathology networks in going digital. Got some stats to say we're already plugged in with over 85 NHS trusts. We're processing, actually that figure of 260,000 samples a year is from last year. So this year we're well on track to be well over 300,000 samples and on track to scan 1 million slides, which we're very proud of, and we've got some really busy scanners going around the clock pretty much. As I said, we really focus on digital pathology integrations up and down the country, and we've got a broad list of consultant pathologists on our books, over 280 of them, who support with reporting needs. So having said that, let me talk you through a little bit, particularly around what makes us stand out. So we've got 2 large laboratories, one in Nottingham, one in Chichester. We pretty much do everything at both sites. So that's really for information and out of interest, because depending on what sort of samples we receive or the complexity of those samples and those cases, we kind of balance the cases internally between our sites and between our staff. But what that means for anyone externally utilizing our services, it doesn't change anything. You just send us your samples and you don't worry about it. We have very stringent requirements that I'll show you in just a moment in terms of onboarding our pathologists. So just to reassure you, anyone that reports for us, they go through a very, very thorough process before they are enabled to do so. And in terms of getting ahead of myself a little bit, but in terms of what Sanj will talk you through, we've got a blockchain-based patient log audit trail as well built in. So that's the next step that we're moving to, is securing our kind of information governance aspects even more. And again, we've got a dedicated team. We like to think we're very approachable to answer any questions that you might have. I'm going to fly right through this nice little graphic to show you that we do everything from wet specimens through to blocks, pre-prepared slides, all the way through to reporting and digital pathology integration support. And again, as promised, because I don't think we've actually ever presented this publicly before, is when we do onboard pathologists for reporting, we do make sure that they tick a lot of boxes. So even if there are individuals that may be based abroad, they will most certainly be GMC registered on the specialist register, participate in EQAs, have the required indemnity, and so on. So we're very, very eager to just highlight that everything we do, quality comes first alongside patient safety. And with that sort of brief, I hope I stuck to brief, introduction, let me hand over to Sanj for talking you through our HIVE LIMS Plus.
Hey everyone. There have always been problems with outsourcing of pathology specimens and outsourcing pathology slides, and we've built an IT platform, LIMS platform, that's completely cloud-based that will hopefully simplify these problems. So it is available online, it's hosted on AWS, there's two-factor authentication to log in, all of the data is encrypted at rest. We have already integrated the system with 2 national LIMS providers and a practice management software, and we've developed things like automatic reporting teams, which means that if you are a particular hospital and you have a preference for a certain set of pathologists to report their cases, you're able to select those pathologists up front. We've got digital second opinions. If there is a challenging case, one pathologist can get the opinion of multiple pathologists at the click of a button, all back on the same day. We have the ability to share these digital images back to the trust that referred the case to us in the first place. If you have localized data sets, which for some reason everyone's gone beyond the LDPath data sets and slightly tweaked them for their own hospitals, we're able to ingest them so that the reports will come back to you in the same format. Similarly, SNOMED coding, we've got everything from version 2 to 3.5, the CT coming in. So if you're on version 2, if you're on 3.5, if you're on 3.5 international, you can send us your codes. The reports will come back in the same format as if they're reported in-house. And we can send you all of these management statistics from the point of procedure to us receiving the slides or the sample, from us receiving it to the slides being available to the pathologist, from the pathologist receiving it to the report being issued, and anything else. And we also have integration with AI providers. And what this effectively means for your histopathology department is that the reports will come back as if they've never been outsourced. They'll be coming back from a set of pathologists that you've pre-selected in your format, in your data set format, with your version of SNOMED, and we'll ingest your stain list directly into our LIMS. So any additional work that we request to you will go directly in a format that is acceptable from your Cerebro or your Vantage system, and it will only be for the repertoire that you stock in-house. I've just got a few images here showing the new system and what it means for the pathologists. They're able to see any notifications in the notification center, and any of those that have been received in the last 24 hours, 48 hours. And the reason that we've built a notification center in the LIMS is you do not, as a pathologist, want to receive an email every time a case is outsourced to you. We're doing 300,000 cases a year at the moment, and if you report 4,000 or 5,000 cases as a pathologist for us, you don't want to receive 5,000 emails. You'd rather get notified directly in the LIMS. You can be notified when a case is released to you, when additional work is requested, when it's received back, when a rescan is requested, when it's received back, if someone's asked a second opinion to you, if there's a case that requires double reporting. Everything can be directly through the LIMS. You've got your cases that are ready to report right now, so that means you've got all of the available material to report the case. You don't need to go in and check, have all of my stains come back. You've got any cases that are pending further work, so there's still some stains outstanding, you've asked 5 second opinions, you've only got 3 of them back, or any cases with open issues that both admin can log, case XYZ is not available, slides arrived broken in transit, or the pathologist can log directly to remove email communication. The macro states 3 pieces of tissue, but I only see 2 pieces of tissue on the slide. How many cases you've reported in the last 48 hours? This was important to our pathologists because a few have told me that in the middle of the night they wake up, I should have requested this stain or added this supplementary report. How do I find out what case it was? Let me just check what I've reported in the last 48 hours. Any digital second opinions received, or any double reporting cases to report. We've got a fully digital pull system similar to any NHS hospital, whereby the pathologist goes and pulls some slides off a shelf and reports them. they have the same ability in our system as long as there's no conflict. So if you do not work for that hospital and you're on the preferred reporting team of that hospital, you're able to just log in at any point of the day and pull cases down. And that's important because at the beginning of every week we ask our pathologists for their capacity. And you might have a spare 10-15 minutes to report some cases that, and you've already exceeded your capacity. We wouldn't allocate any more cases to you. The pull system allows pathologists to self-allocate cases for reporting. There's some logic on there as well to prevent somebody from gaming the system. So you can only pull down 5 cases at once, and you can only have 5 unactioned cases at any time. Actioning a case means additional work requests, second opinions, or a provisional diagnosis needs to be sent out. And finally, I've just got a little image showing our data set manager. So say, for example, your hospital reports your SCCs in a particular way. We've got these triggers at the top, which are the SNOMED codes, the TPs and Ms, and if the right combination is met, skin, excision, SCC, the microscopy-free text box automatically changes into the data set that that hospital requires for reporting. And all in all, everything tries to get reports back to you directly integrated into your system if we've set up an integration with your provider yet, in the same format as if they were reported in-house. And if you've got your own scanners, the next logical step is for you to scan directly to us. We've got a few clients in the room today that are scanning their slides directly to us. So if there is an urgent case for MDM or anything else, the slides have never actually left your hospital, saving about 2 days in transit time of sending cases to us and getting slides returned back. And I will hand over to Debra.
There's someone in the audience very concerned that the battery's going to go flat on the iPad, so on the laptop, so thank you ever so much. And someone else has also commented that some people at the back are struggling to hear some of our speakers, so we maybe want to just have a little think.
Shout into the mic.
Yeah, I'm a Geordie, so I never have an issue with being heard, generally. So there you go. Morning, everybody. Lovely to see everybody and lots of familiar faces in the room. For those of you that don't know me, I'm Debra Padgett. I'm the immediate past president of the Institute of Biomedical Science. That's my extracurricular activity. I'm going to badge it as that from now on, following Sarah. But I'm also North East and North Cumbria Network Operational Lead and Clinical Pathology Lead at Northumbria. So, Klaudyna's very nicely teed us up for why I'm here today. And really, this is about a piece of work that's been ongoing for probably the last 6 to 8 months or so, around a working group that I have had the pleasure of hosting and chairing, with Source being our key facilitators in how we deliver that. They are there purely to provide that, how they pull us all together and put us in a room. And we are doing this almost independently of Source. But thank you for all of your help in getting us this far, because we absolutely need it. We came together really because of the space that we're working in currently within histopathology and the digital pathology landscape, and the sheer volume of change that we are all facing every day. That's not just implementation of digital with a view to artificial intelligence, but the workforce challenges that we currently have, the never-ending increase in activity, but not only in activity, the complexity of the cases that we're also seeing. And obviously we have the eye of government just at the moment because, sadly, of the cancer backlog caused by COVID-19. But we also have to understand how we revolutionise the way we work, how we look at different processes and process mapping within our services to get the best out of that. So we came together really to, as the slide says, to shape some key recommendations for advancing digital pathology. It is without doubt the way we are going to make most efficiency in our histopathology services. But we really want to do that sitting alongside our NHS colleagues. A huge amount of work has already been done on the London Histopathology Review, the forerunner to the NHS Histopathology 6-point plan. But we need to then start to see some key action plans and activities that come off the back of it. So, as I say, I was approached to chair. I had the pleasure of working, and still have the pleasure of working, with some esteemed colleagues, those of which are on the screen in front of you there, all of which who are key thought leaders in the field of histopathology, either clinical or operational, because we can't do this one without the other. They do go hand in glove. Around how we're going to make most use of our services. So, over the course of those two key meetings that we've come together where we really want to get to, and again, as I say, working alongside our NHSE colleagues, but also broadening that out to the whole of the 4 nations across the UK, because this is not a problem that is unique to England. It is a wicked problem that we are all facing with cancer backlogs. We really feel that we have got to a place where we can now start to look at some key recommendations, and been working with a policy group to be able to publish our white paper with some key recommendations by the end of this year. I'm not going to go through it all, don't panic. I only have 5 minutes, and I'm very aware I'm standing between you and the next cup of coffee, which is really important this morning, I think. But there are some key focal areas up on the board in front of you that the report will really focus on, not limited at all to the fact that we need a culture change within the service and the scope that we are currently providing. We currently talk about histopathology and digital pathology. They are one in the same, and until we start to consider them as one in the same, we do have a problem. So really that culture change around how we're going to deliver histopathology with digital as a key enabler of that is absolutely critical. One size doesn't fit all, we are completely aware of that, but having a national framework around how we develop, deploy, and really manage that continual improvement of our services to get to a place where we can lead with artificial intelligence is absolutely critical. We are working in silos, and there's a lot that we can do, not just within networks, but across England as a whole, to share the work that we're already doing, to look at validation and verification, and to really maximise that rollout and deployment of systems more effectively. We can only do that if we have better engagement, and that's some of the work that we're looking at around not only how we involve our procurement teams and ongoing system suppliers and providers, but also how we link in with that national funding programme. Digital pathology is not without the money. There has been an awful lot of money put into the system. What there hasn't been is ongoing revenue funding and ongoing support of these systems, without which we keep peaking and troughing in how we deliver service. Nor has there also been the funding for the resource to be able to deploy appropriately. So how do we go about those sorts of things? And then let's not forget, our patient is the core of everything that we do every day. So how do we ensure that we have that level of focus and learn some of the lessons from our radiology colleagues around what digital pathology has delivered or could deliver in line with the same way that digital radiology is delivering for patients in that area of diagnostics, but also how we make sure that they understand that when their biopsy is taken, where it is going to. So we're back on that visibility piece again. So there's some key recommendations around all of those areas. I can't wait to see the report and the publication. I'm sure it'll be fantastic. And we'll come together again to talk about what that's going to mean for the future. So thank you.
Thank you very much, Debra, Klaudyna and Sanj. I think we've got time for maybe a couple of questions. Roaming mics are coming to a place near you, so hands up. Any questions for our colleagues? Right here, Supriya. Do you want to stand and maybe come near the mic so when you speak you can shout it out and people can hear?
Thank you very much. So I'm Supriya Joshi, I'm the Clinical Director of the Cantonal Pathology Network. Debra, my question is to you. I think my head was going to fall off with all the nodding that I was doing. So my question specifically is about governance around AI. So we try to be super organised and express our interest in implementing AI-assisted prostate reporting, much like Wales, following the implementation of digital pathology. But our CCIOs did not know how to help us with this. So is there a sort of national guidance around governance of AI?
Hi there, thank you. I'm not going to stand up and come back over there, I'm going to stay here. I think this is one of the problems that we're facing at the moment, and when we talk about that national framework, that isn't just for digital pathology, it's how we approach AI deployment, how we get confidence in systems and ensure that we have the rigorous governance processes in place, We have a lot of learning to do around this, but again, our radiology colleagues have gone before us. So if your CCIOs are happy with how they are managing AI review of their chest x-rays, how do we build on that and manage forward into our pathology agendas and arenas as well? We have to stop thinking, not only, as I've seen there's a question around digital pathology, but also digital hematology, and yes, they're one and the same. This is digital delivery of traditional pathology services, and we have to link it back into the wider diagnostics sphere and take that learning from radiology as well.
I have suspicion they didn't ask them.
There's one at the, yeah, there we go.
Hi, Andrew Nicholson again. Not normally this inquisitive, but two comments. One is a conflict of interest. I use LDPath, and it is a good system. And I guess a comment for Debra is that what I find when you use some of the other digital systems is they're not that integrated. And you go on and you look at a digital slide, then you've got to go onto your patient sort of database to look at the clinical details, then you've got to go into another one to do the report.
Yeah.
So you end up with 5 different interfaces, and it becomes time inefficient, basically. So as a plea is the integration is very good, and this is a very good system in my opinion. My question for Sanj though is, in relation to you say you're processing a lot of samples. Who does your cut-ups, and are you having the same issues in staffing these things and staffing your scanning and staffing your laboratories?
So staffing, there's a BMS shortage up and down the country. I think the advantage that we've got is that we are next to 2 teaching hospitals, our laboratories, and we've got probably 20 to 30 pathologists that work for us from close by to the laboratory. So any complex dissections we're able to have our pathologists assist us with. Similarly, we've got a training program at Source Bioscience. We've got some advanced dissection BMSs working for us, and we've got a camera between the 2 laboratories. So if there is ever a case that requires complex dissection, we're able to have advice from one pathologist in one laboratory, go through the MacroPath system to the other laboratory. So staffing, I think we've got a slight advantage in that we're not prohibited by banded pay scales. As a private organisation, we can pay more referral fees and things like that. But we're also very lucky that we've got our pathologists that are geographically close to both of our laboratories.
Thank you all very much. Thank you once again to our speakers for sharing your thoughts and all the exciting things that are going on.